Good morning, everyone. My name is Dr. Monica Padilla, and as a clinical program manager at InBody USA, I want to welcome all of you to today's webinar in our InBody Present series. Today, Dr. Katie Hirsch will be speaking to us about body composition and improving the assessment of fat-free mass. Dr. Hirsch is a postdoctoral research fellow in the Center for Translational Research in Aging and Longevity at the University of Arkansas for Medical Sciences. Currently, she works with Drs. Paul Wolfe and Arnie Ferrando, conducting research on the effects of exercise, nutrition, and stress on muscle and protein metabolism. Dr. Hirsch has a PhD in Human Movement Science from the University of North Carolina at Chapel Hill, and is also an ACSM certified exercise physiologist and an ISSN certified sports nutritionist. During the talk, as well as after, attendees will have a chance to ask her questions by adding them to the Q&A section on your screen. Without further ado, I'd like to welcome our guest speaker, Dr. Katie Hirsch, to join us.
Thank you, Monica. I'm excited to be here with you all today. So thanks for joining me to talk about body composition and improving the assessment of fat-free mass. So as Monica mentioned, let me see here. I am currently a postdoctoral research fellow working with Drs. Bob Wolfe and Arnie Ferrando, where we specialize in using isotope tracers to study effects of exercise and nutritional interventions on muscle and protein metabolism. But a lot of the data I'm going to present today, I actually was involved with during my PhD work at the University of North Carolina, where I studied under Dr. Abby Smith-Ryan. And a lot of the research that Dr. Smith-Ryan does there at UNC looks at the effects of exercise and nutritional interventions on body composition and metabolism. And we also did a lot of work validating different body composition devices and assessments, and how can we improve those measurements. So again, that's a lot of the data I'm going to present today. So to kind of kick things off, let's talk about what is body composition and why do we really care about good measurements of body composition? And so, as I'm sure most of you are really familiar, body composition, we tend to think about a measurement of percent body fat or just body or fat mass in general. But really, body composition is the quantification of all the core components of the body. So that's going to include not only fat mass, but also fat-free mass. So that's going to be muscles, organs, tissue, body water, and even our bones. And so really considering all of these different components is not only going to be important for characterizing populations or individuals, but it's also going to be really important for things like health risk. So we're all pretty familiar with the risks of being overweight or having excess body fat, but being underweight also carries a lot of health implications. So maybe fluid electrolyte imbalances, in a lot of older populations, muscle wasting, osteoporosis, those are going to be a lot of big concerns or issues. Even patients that are maybe in a hospital long-term and are suffering from malnutrition, the underweight risk is going to be a problem for them. Another area that body composition is going to be important is to assess the effectiveness of an intervention. So again, a lot of us think about the weight loss scenario. And so how effective is our exercise or nutrition for helping people lose weight? But on the flip side, maybe we're also interested in how do we help people gain weight and gain healthy weight. So for example, in a surgical population, after we have hip or knee replacement, how do we gain that muscle mass that we lost during that time when we were inactive? And then finally, maybe a more specific population would be for the improvement of athletic performance. So if we think of our high-level elite athletes, how do we help those individuals not only be at a body weight or composition that's going to maximize their performance, but also help them stay healthy and injury-free? Now, performance doesn't just apply to athletes. This could also just be your everyday individual or even your older individual who's just trying to keep up with grandkids or prevent slips, trips, and falls. So making sure we're at a spot where we can be appropriately active to improve our quality of life. And then finally, kind of an area I do some research in is a military population. So how do we keep them healthy, doing their jobs appropriately, and avoiding injury while they're on the job? So to kind of give you an example of why considering all the components of body composition rather than just maybe percent body fat is going to be really important. So this is an example of a 20-something-year-old female. Over the last couple years, she experienced some weight gain. And so she gets with a professional to make some diet exercise changes to get back to a weight that she feels a little bit better at. And so in tracking weight, which is what most people only track when they look at a diet and exercise intervention, 7 months after making these changes, we see that she had some gain in weight. Okay, maybe not what she was wanting, but she sticks with it. It's only been 7 months. A year after making these changes, she sees an even greater increase in weight. Definitely not what she's hoping for. So she's already 6 pounds more than where she started, now 15 pounds more than maybe where she originally wanted to be. So if all we tracked is weight, she's probably thinking this intervention's not working. I don't want to continue this. I'm going to do something else. But if we consider percent body fat, at least a component of body composition, we see that over that same time period, she actually decreased percent body fat. Okay, so that's a little more encouraging. But over the course of the year, there was really only a 1% decrease, which maybe isn't super thrilling. So instead, we take a step further, and if we consider body fat in pounds, we see over that time period, there was no change in body fat. So initially, maybe she's thinking that's maybe not what she wanted, but if we consider that she had weight gain, but none of it was coming from fat mass, that's a positive. So we take it one step further and we see that actually over that time period, she had pretty large changes in lean body mass, which is a healthier weight change. So in considering all of that, now she's thinking, okay, that weight change maybe wasn't so bad after all, or a negative thing. And so she sticks with the diet and exercise program, and actually just 6 months later, she starts to see significant changes in weight. That percent body fat drops. She does lose some body fat and relatively able to maintain that lean mass that she gained. So this is just an easy, maybe common situation for people trying to lose weight, but why it's important to maybe look a little bit further than just weight or just percent body fat and really break down those segments and help people see where these changes are coming from and to evaluate what maybe next steps need to be. All right, so to move forward with how do we assess body composition, specifically that fat-free mass component? So the most common way to do this is with something called a 2-compartment model. So this is where we just break the body into the 2 components, fat mass and fat-free mass. Usually this is quick and easy, simple, doesn't take a lot of time, not a lot of burden on the participant. So if you were to use your InBody for this type of analysis, which you can definitely do, on your report sheet here, those numbers come out as this body fat mass number here at the bottom, and then your lean body mass measurement here. And so if we look at how well InBody quantifies these 2 components, we see that looking at percent fat and fat mass, that on average, InBody does a really nice job estimating body fat. So compared to a gold standard 4-compartment model here, we see minimal differences on average. If we look at an individual level, there's more error and variability at the individual level, and the InBody may have a tendency to slightly overestimate percent body fat. But as long as we're following pre-testing guidelines, we're probably going to get a pretty good estimate of percent body fat. And so we see that that holds true not only in men and women, but also holds true across races and ethnicities. And so this was a really nice study that we just completed at UNC by Dr. Malia Blue. This was her dissertation. And so if we compared the InBody to that gold standard 4-compartment criterion, we see they match up really well across all races and ethnicities, doing better even than DEXA, which has a tendency to overestimate percent body fat, and then compared to the BOD-POD, which has a tendency to underestimate percent body fat. So great results there. If we look at how well InBody measures fat-free mass, we also see really good agreement. So similar story. On average, fat-free mass estimates from the InBody compared really well to that 4-compartment model. At the individual level, again, there's going to be more variability, as you can see in this chart, with maybe a slight tendency to underestimate fat-free mass. But we can expect a pretty good job in men and women. And again, that's holding true across all races, ethnicities, doing a better job again than DEXA and BOD-POD. All right, so going back to that 2-compartment model, a lot of times people, when they think of fat-free mass, they jump to muscle mass, that's what it's quantifying. Or if we see changes in fat-free mass, it must have been due to changes in muscle mass. But it's really, really important to remember that fat-free mass is really anything that's not fat mass. So that's going to include things like organs, tissues, body water, and bone, kind of like I mentioned earlier. And so each of these components might be affected differently in different scenarios. So these are just a few examples where each of these components might vary a little bit differently or be impacted differently. And so it might be really important that we consider what's the changes in some of these components specifically, so we really understand what's going on with changes in fat-free mass. So an easy example, really good example of this is bariatric surgery. And so if you're not familiar with what that is, that's the stomach reduction surgery or stomach bypass surgery. And a big concern with that surgery, even though it's the most effective approach to weight loss, there's really high loss of fat-free mass when you do that. We're bypassing the stomach, so that makes sense. But that puts these individuals at risk for reduced metabolic rate, maybe some loss of strength, functionality, quality of life, maybe even impacting longevity. So it's really important that we maintain fat-free mass. And so we did a study in bariatric patients a few years back where we were able to really get good measures of that change in body composition. And so with this study, we used a bioelectrical impedance device. This is really common in bariatric patients. It's quick, it's easy, they just stand on it, it only takes a minute. And so if we quantified fat-free mass change over the first 3 weeks post-surgery, we saw that on average, individuals lost 6.6 kilograms of fat-free mass. Now, if we equate that 100% to a loss of muscle, that's really alarming. That's a large amount of muscle lost in just 3 weeks. But because we used a bioelectrical impedance device, we were able to quantify and look at what was the change in body water, which is something that bioelectrical impedance is really good at quantifying, and then maybe what was actually due to tissue. And what we saw is over that 3 weeks, about 2/3 of that loss of fat-free mass could be attributed potentially to loss of water, whereas only 1/3 was maybe a loss of actual tissue or other components of fat-free mass. And so this is just to kind of show that it's really important to consider what's happening with those other components of fat-free mass before we just jump to conclusions that it's completely muscle-based. And so if you were using your InBody in this scenario, if we look at that report sheet, rather than just looking at the total lean body mass measure, maybe we dig a little deeper, look at what's happening with total body water, and then dry lean mass, which is going to quantify those other components of fat-free mass. So just digging a little bit deeper, getting a better picture of what's happening in your person that you're working with. And so looking a little deeper at body water, we see body water is actually a really large component of our fat-free mass. Humans carry a lot of water, and it's also one of the more variable component. And so there's a lot of scenarios and situations where body water varies between all of these situations. And so getting a good measure of body water can really improve our estimates of fat-free mass and give us a better picture of what's happening. And so again, as I mentioned, bioelectrical impedance is a great way to do this, and the InBody happens to be exceptional at this. So during my time at UNC, we were able to compare InBody measures of total body water to a gold standard estimate using deuterium. And what we saw is that InBody does an excellent job estimating body water, considered very good to excellent across all races, ethnicities, and men and women, with very low error rates. And it actually did better than another commercially available device that we had. So the InBody is great for quantifying these body water changes. And so what we then do in research a lot of times is take that body water measure from something like the InBody and add it to our 2-compartment model, creating something called a 3-compartment model. And really, as you can see, when we add that body water measure here, we're accounting for a lot larger component of that free mass, fat-free mass again, and we really only have to estimate protein and mineral. If we compare that to the DEXA, which is considered by many a gold standard measure, we can see DEXA is really only getting a true estimate of body mineral or bone and has to make assumptions about the rest of this lean mass component. So there's the potential for more variability to happen. Still a good device to use, just differences in how it's estimating that fat-free mass component or lean body mass. And so really with research, the more components of that fat-free mass you can account for, the more accurate of an estimate you can get and the lower the amount of error. So if you need a really precise measure or for tracking, it's going to be good to account for more components. So easy ways we do this, if you have access to a bod pod, you can add a simple measure of body water to that body density that you get from a bod pod, which creates this series 3-compartment model, which significantly improves your estimate of body composition and reduces your estimate error. We can take it one step further, and if we account for body water and bone density, we create what is considered a true gold standard measure or a 4-compartment model. And so this is what we use a lot in a research setting. Obviously, this starts to get really expensive. You have to have all of these really nice devices in order to do this, but maybe in an older population that we're studying, this could be really important that we quantify long-term what's happening to bone, what's happening to water, so that we can really get an idea of what's happening to that fat-free mass component. All right, so moving forward, some other situations or components of the fat-free mass that we may want to consider. One of those being segmental assessments of fat-free mass or lean body mass. And so as of right now, the InBody and the DEXA are really the only 2 devices that easily give us a good segmental quantification of arm and leg composition. And this is going to be important for situations maybe post-surgery. So if I have a knee replacement, hip replacement, shoulder surgery, what was the loss in fat-free mass during the time that that joint and those muscles were immobile? Maybe also I have an athlete who recently had an injury, and if we're going to get them to return to play status, maybe we need to work with them to get that muscle mass back up, make sure we have equal balance across the body. So segmental quantification going to be really important in a lot of different scenarios. So if we compare how well InBody measurements of arm and leg fat-free mass compare to those of the DEXA, we see that InBody tends to underestimate arm and leg fat-free mass. And so that tends to be a little bit greater difference in males compared to females. Those differences are thought to potentially be related to, again, body water components such as tissue hydration, extracellular fluid, and maybe height or limb differences or ratios. But really something, so if you compare the two devices, they are going to be different. But if we look at how well the two of them track changes, which is maybe something we're more interested in, we see that there's actually really good agreement between the two. So similar to our whole body measures of composition, on average, changes in segmental lean mass from the InBody compare really well to those of the DEXA. So just tracking changes, they both do agree on the amount of change. At the individual level, again, there's going to be more variability, but again, you can usually get a good change. So the recommendation here would be whichever device you're originally tested on, you just want to stick with that device and follow those pre-testing guidelines, measure at the same time of day, and you can do a really good job tracking those changes and making sure we're getting good segmental agreement across the body, getting people back up to where we need them to get to. Now, beyond just segmental muscle size, something we're really interested in research is muscle quality. And so kind of what that refers to is, if you look at this picture on the side, we see that with age and sedentary behavior, we not only lose muscle size here, this dark tissue, but we also see fatty infiltration of the muscle. And as we get fat infiltration within the muscle, that has a lot of implications for reduced strength, quality of life, really highly associated with the development of insulin resistance and cardiometabolic diseases. So especially in older individuals where it's hard to increase lean mass to a large degree, it's going to be really important that we at least help them maintain good quality muscle. And so the gold standard way to look at muscle quality would be with a biopsy or with a CT scan, which is what you're looking at here. But those approaches are pretty invasive, really expensive, maybe not something the average individual can do. That's more of a lab-based measure. So right now, what we do in the lab that's a little less invasive is we look at ultrasound. And so with an ultrasound, we can still get a good cross-sectional image of those muscles. Here you're looking at the vastus lateralis. And by tracing that muscle, we can get a good look at cross-sectional area or muscle size. And we can also do a grayscale analysis on this image, which gives us a good estimate of muscle quality, representing in dark the contractile tissue of the muscle. And then this white and gray matter is going to be non-contractile tissue, so fatty tissue and connective tissue, things that aren't going to help muscle quality necessarily. Now, this works really well, gives us a good indication of muscle quality, but it's still kind of expensive. And this takes a lot of analysis work on the back end, a lot of time, which most people don't have time to do. So kind of a direction we've started to look at is how we can use measures from the InBody to look at this. So what we're looking at is how can we use the raw electrical signals from these segmental measures of the body with the InBody to look at cell integrity and health, and maybe what does that tell us about muscle quality. So just real quick, if you're not familiar, the raw electrical signal measures from the InBody are resistance and reactance. And again, those give us indications of cell integrity and health. At the whole body level, we can use those to look at something called phase angle, which right now is used a lot to look at nutritional status, but also tells us a lot about hydration status and maybe muscular and body composition status. So if we take that and scale it down just to maybe the leg or the arm, that's where we started to look at is what does that tell us about the composition of that particular segment. And so this is a poster from a group that I collaborated with at UNC, where they took those ultrasound scans of muscle size and quality and compared them to those raw frequency signals that we get from the InBody. And kind of in summary, what they saw is that the frequency characteristics were highly related to muscle size, such that a higher characteristic frequency was related to smaller muscle sizes, whereas that phase angle was highly related to the muscle quality measure from the ultrasound. So a higher phase angle representing better muscle quality. And so this is really preliminary work, but it was suggested that a segmental bioelectrical impedance measure with those raw values might serve as a good cost and time effective way to monitor muscle size and especially quality in population. So this is something, if we can develop it further, develop some numbers or scales that people could use really quickly and rapidly to look beyond just muscle mass, but also the quality of the muscle. So to kind of just wrap this all up and summarize, the InBody does provide really valid and reliable estimates of fat mass and fat-free mass, doing a good job in men, women, across all races, ethnicities. It is really important to remember that fat-free mass is not just muscle, but also organs, tissues, body water, and bone. That body water component especially is one of our more variable components of the fat-free mass segment. And InBody does a really good job of quantifying total body water. So it's going to be a good device for you to consider that segment. And then when looking at segmental lean mass, again, InBody does a good job tracking changes. They will be different than what's read on a DEXA, but can be used really well to track segmental changes. And then finally, future areas of research we're looking at is how do we use those raw frequency and phase angle measures within a segmental component to look at muscle size and quality. And so with that, thank you for tuning in today. I do just want to say thanks to my collaborators at UAMS, Drs. Ferrando, Wolf, and Church, as well as a big kudos to Dr. Abby Smith-Ryan, Dr. Malia Blue, at the University of North Carolina. All of this data came from them, worked really closely with them the last 6 years. So I'll now open it up to questions.
Thank you so much, Dr. Hirsch, for sharing the work you're doing in translational research. At this time, we would like to take some questions from our audience. As a reminder to all attendees, you can send in your questions to our speakers using the Q&A chat box at the bottom of your screen. Okay, so we already have some questions here. You mentioned earlier, Dr. Hirsch, during the talk, that it is InBody is better than DEXA for assessing fat mass and fat-free mass. And that you can compare to the 4C model, which uses different bod pod besides just InBody to be able to complete that the 4-compartmental model. So it seems that regardless of racial and ethnic background, InBody maintains its accuracy. Why is this important or a focus in some of these studies? And are you looking at future applications or intervention effects where the InBody should be used because of this?
Yeah, so some of the interest from Dr. Blue's dissertation, kind of the driving factor for that is there are known composition differences by race and ethnicity as well as by sex. So that study particularly, we really broke it down by race, ethnicity. There's differences in body composition distribution, as well as like limb to trunk anthropometric ratios across the body, which could impact the accuracy of different devices. There's also just differences in things like bone density, lots of different factors that just are a genetic difference between different individuals. And so the thought was kind of, if you're working with a specific population, we want to make sure we're getting them the best measurement of body composition we can get, especially since measures of percent body fat and fat-free mass are really highly associated with cardiovascular, cardiometabolic disease risk. So we want to make sure we're getting an accurate measure for all individuals so that we can most accurately treat them and help them be healthier. So that was kind of the driving factor behind that, is making sure we're providing all individuals with good measures. And what we saw with that data is InBody was really consistent across all races and ethnicities. So if there's only one device you can use, InBodies may be a really good choice and going to be quick and easy, give those individuals good measures. So something to consider. Not to say that a bod pod or a DEXA is necessarily bad, they just make different assumptions. So all devices have their limitations and assumptions that we just need to make sure we're accounting for.
Great, thank you so much. Also here they're asking if you could explain a little more how the 4-compartmental model analysis is done.
Mm-hmm. So the 4-compartment model, like I mentioned, includes a measurement of body mass, which you just get from standing on a scale. We also include the body density or body volume measure from the bod pod, which is what it was designed to measure. That's its best measurement. Same thing, we then also include that body water component from the InBody, which again is maybe one of InBody's strongest measurements. It's a more direct measure of body water. And then from the DEXA, we take a really good measure of bone density. So DEXA was originally designed to assess bone density measures. That's its best measurement. Mm-hmm. And so if we take all of those components, we're now accounting for that more variability or different parts of that fat-free mass. So we can get a better picture or a more accurate estimation of body fat and fat-free mass when we go to calculate it out. So again, that's the gold standard measurement. That's the best you can do. There are 5 and 6 compartment models that get really expensive and are really, really technical to do. But we've seen that a 4-compartment model compares really well to those. So this is going to be the absolute best. Now, it's not really feasible for a doctor's office or in a gym or for a lot of individuals. But if you have access or the ability to do that, you can. So something to consider, just even dropping to a 3-compartment model where we added body water to the bod pod, that really improves accuracy as well. So just things to consider, weighing the pros and cons of how accurate of a measure do you really need.
Okay, so just kind of to follow up on that then, what you stated right now, you would think then 4-compartmental models are really not necessarily, will be optimal if you have the chance to have all the equipment, but depending on the application you have, is probably not necessary, right?
Right, yeah. I'd say for just the average individual wanting to track their health, you don't necessarily need a 4-compartment model. This is going to be important for maybe research purposes where we're trying to control for high amounts of variability to really get precise changes over time.
Okay, thank you so much. Here we have a question for the audience. They are talking about the paper by AFE on 2019. So they're asking, based on that paper, how important do you think it might be to try and correct for the fat-free mass component of adipose tissue when looking at the effect of longitudinal interventions?
Which paper was it referencing again?
AFE 2019, so I'm not sure if you are familiar with it.
I think I've looked at that one. I am familiar with the fat-free mass component of adipose tissue, and that's something we've had a lot of discussions about, is how much that influences changes. So I think it's something we need to look more into. I know especially in larger, more overweight, obese individuals, there's the thought that that has a higher contribution But it's something I would need to look more into. And I think it's definitely an area of future research of how do we even account for that, and if our measurements are precise enough to account for that.
Thank you so much. Also, we have another question here. Do you have any comments on water measurement in heart failure and for compartmental measurements in cancer cachexia?
I specifically do not, but I know there's a lot of people looking at, I have not worked with cachexia specifically, but it is an interesting area. I know I've talked to individuals who specialize more in that. And so I think a 4-compartment model with research in that area would be really insightful and help us to get a better picture of maybe what's fully happening in those scenarios. So I do think it's applicable, not something I have direct experience with though.
Thank you so much. Also, they're asking, do you currently conduct any research with individuals with other health conditions that might mask change with lean body mass, for example, lymphedema, or with injured athletes? And as you mentioned, water values can play a role. Have you considered looking into ICW versus ECW changes, for example?
Yeah, so I don't do a lot with the edema and types of things, but that is relevant in a lot of populations that I might work with. My general recommendation would just be to take that further step rather than just looking at fat-free, total body fat-free mass, lean body mass, but taking that extra step if you know that's an issue in that population to see what are the body water changes, what are the intracellular and extracellular water changes, and what is that telling you about that population. So I think it's just a population awareness of really digging a little bit deeper and saying, where are the changes and what do those changes tell us? And you can get a lot of that information from the InBody. It gives a lot of that great information segmentally and total body. So it would be a great thing to consider in those groups.
Thank you so much. Somebody's also asking, what made you decide to utilize the InBody versus all other BIA devices?
So honestly, in my research and work at UNC with Dr. Smith-Ryan, because we specialized in body composition measures and validation, we have all the fun body comp toys there. And so access to lots of different devices. But I think the draw to something like an InBody is the level of information that it gives back to you. Not only total body, but segmental, like I mentioned. There's not a lot of devices or approaches to body comp that give you those segmental outcomes. So that's really valuable, as well as then looking more into what do the segmental body water or electrical frequencies or phase angles, what does all of that maybe tell us? So I think there's a lot more to explore with what the InBody could tell us. So it gives a lot of great information, and I think we're just continuing to expand on what we can draw from that.
Yeah, definitely. So a lot more to look at in your future research, right?
Exactly.
And for example, somebody is asking here, if you have, in that tone, have you considered looking at visceral fat values in the future?
Yes, so visceral fat is something I've actually done a decent amount of work with. If you don't mind, is it okay if I switch back to my slides really fast?
Yeah, you can do that.
So I did include a few extra slides that I didn't discuss that kind of show what we've done with visceral fat. So my talk today, I focused on more of the fat-free mass components. But visceral fat is something that I think is really important to consider, especially when we're looking at cardiometabolic disease risk. And we've even seen that normal weight individuals by BMI can have high amounts of visceral fat that places them at higher disease risk. So this is something that's really important to pay attention to in all individuals, that this is not just an obesity thing. And so right now, the gold standard way to measure visceral fat is, again, with a CT scan, but that's really not accessible to most people. So DEXA does do a visceral scan. It does an estimate with some algorithms about what's the visceral fat in that area. So that works well, but again, a DEXA is expensive and not everyone has access to that. So another way we can quantify visceral or abdominal fat is with an ultrasound. So here we're measuring visceral thickness between the abdominal muscles and the back of the posterior side of the aorta. And that kind of gives us an indirect estimate of visceral fat. But this, again, takes the device and then it takes some skill. It's not the most initially intuitive thing. And so finally, then, as you're all aware, the InBody does give an estimate of visceral fat. So something I did, this is a poster I presented, let's see. Yep, there it is. Last summer at the American College of Sports Medicine, where we compared estimates of visceral fat across DEXA, InBody, and ultrasound, just to see how well they agree, if they're all tracking similarly, if they're not. Again, these are all just estimates of that component, but kind of the conclusion of that, we saw that compared to a DEXA, so we kind of considered that our gold standard in this scenario, but InBody and ultrasound both agreed well with DEXA. They correlated pretty well, but InBody did a better job, especially in women. So in women, if we look at the ultrasound, there was a little bit more variability in its agreement with the DEXA, whereas the InBody, there was much stronger agreement between those estimates. So really, that's just to say, I think it's something we need to keep considering and looking at, but it could be a really good way to at least track that and get an idea, and something we want to pay attention to in a lot of populations.
Okay, thank you so much for sharing that with us.
Yeah.
Okay, let me go back to share the slide we have here. Okay, we still have more and more questions coming in. So you have talked about how you can apply to different populations. Somebody's asking specifically to older adult population, 63 plus. How would you specifically apply this to them? These kind of parameters.
Yeah, so this is honestly, these types of measures apply to all individuals. Here at the University of Medical Sciences here in Arkansas, we study aging populations, do a lot of work in individuals older than 65. And so actually quantifying body composition is going to be really important in this group because we do see deterioration across all those different segments. So a lot of what my research here does is how do we mitigate muscle loss with aging? How do we then maintain bone density and all those different factors? So a lot of my focus is targeting the muscle, because if we have good, strong muscles, we tend to have good, strong bones, lots of things. So InBody is going to work well in these populations, really easy for them to stand up on, do. So everything I talked about, again, can apply to this older group, and maybe considering the different components and that's happening in their life, whatever their disease state, health concern is, just making sure we're considering the component that's being impacted the most. I don't know if that answered the question, but
yeah, I think that helps a lot. And kind of related to that, somebody here is already thanking you for the very informative talk, and they wanted to see if you could share some insights on how muscle size may correlate with muscle quality, and how could we look at both parameters for evaluating lean body?
Yeah, that's a good question. So size and quality, I think, don't necessarily go hand in hand. Something I think a lot of people forget about is obese individuals actually have high amounts of muscle mass as a result of having to carry more weight. And so they might have larger muscles, but especially if they're sedentary, those larger muscles might be poorer quality. Now, vice versa, something I studied during my master's thesis was actually characterizing what it means to be a metabolically healthy obese individual. So this idea that maybe I have excess body fat, but I'm not showing signs of insulin resistance or high cholesterol, things like that. And something we kind of consider with that group is because they're maybe a little more active, they're maintaining good muscle quality. And so that's why it's really important, I think, with this future research is how do we make muscle quality a more feasible measure for people to consider, because it is something that doesn't necessarily translate with muscle size. So I gave the obesity example. In older individuals, it would be the same thing. A lot of times we're more focused on how do we just improve the quality of the muscle rather than just targeting the size of it. It's a lot harder to get hypertrophy in those individuals. Same thing with, you could have a young, healthy college student that's just really sedentary. So again, we did a lot of work on what's called normal weight obesity. And those are the individuals who have high visceral fat and have poor muscle quality, which puts them at risk for diseases, but they're not initially picked up on because they're a normal BMI. So I think it's an area that as we learn more about it, make that measurement more feasible, something we'll want to consider more in our assessment of health.
Thank you so much. That was very helpful, I think, for everybody. To what extent do you use body composition for nutritional advice? Do you use fat-free mass to calculate kilocalories, macronutrients, for example, protein intake? To what extent does this differ from using weight alone? And also following that, to what extent do you consider ECW ratio in the assessment of fat-free mass?
Yeah, so with giving nutritional advice, definitely body composition is helpful. So like I mentioned, weight, while it is a good outcome and gives us information, like I showed in that very first example with the weight loss, weight is just a number, and it's the total sum of body fat and all the fat-free mass components. So it's not super informative as far as where the changes are coming from. And so anytime you can calculate calories or macronutrient distribution off of composition, that's going to help tremendously. So if all I do is calculate protein needs based off of weight, that could get skewed if I have an individual with maybe lower muscle, higher body fat. Now, I mean, arguably that might be helpful for them. We want to maybe encourage them to consume more protein, but you're going to get a more accurate estimate if we can use something like fat-free mass. Definitely the same with an estimate of total energy expenditure. If we can account for how much fat-free mass, which is a big driver and component of energy expenditure, that's going to be really important. So definitely use body comp there. I forget what the second part of that question was.
Yeah, but I think following to that, they're asking us how reliable are the extracellular and intracellular water calculations by the scale, and how best are you using those values, or are you being able to use them?
Yeah, so it's not something I've dug into a lot. It's definitely been part of our conversations as far as when we look more at body water changes. Is it intracellular, extracellular? What are the implications of that for health? So I can't speak directly to the validity and reliability of those measures. That's not something we've evaluated at this point. But you know, if that's an area that you know is important with your population, maybe something to pay attention to, something we can validate more in the future, but not something I have directly implemented at this point.
Yeah, and really, you know, I think that's kind of the thing we're using for calculating the fat-free mass with the InBody. So we can follow up more, you know, and you can contact us for that kind of explanation, I think, directly. How much do you use the phase angle in terms of the individual health?
For me personally, it's not something I have had the opportunity to implement yet. But in reading about it, it seems that there's a decent amount of literature in clinical populations to evaluate nutritional status. So maybe if you have someone long-term in the hospital, that's maybe where they're tending to use it. But from my reading and just my interest in it, it seems that right now a lot of that data is correlational or associative. So I maybe just haven't seen it yet, but from what I've seen, we have these phase angle measures, and it's correlating with things like glycogen depletion or changes in body water or whatever we think the explanation is, but there's not a lot of direct comparison between or measurements of what's happening to the change in body composition and then what's being quantified in the phase angle. So a direction I have some interest in is maybe teasing that out a little bit more and understanding what all is going into that measurement, what's actually happening at the body, and maybe teasing out a little bit better of what is it actually telling us that's happening at the body. Right now, I think it's making up a lot of different components. So definitely a interesting and up and coming area of research. I think a lot of people have interest in this area right now.
Thank you so much, Dr. Hirsch. Here's another one. Have you studied the BMR on InBody for accuracy?
Have I studied the BMR on InBody for accuracy? Oh, its estimate of BMR? Is that what it's referring to?
Yes.
So yeah, I have not. My research, a lot of what I do, I directly, or I do a more accurate measure, arguably, of BMR with indirect calorimetry. So I tend to just directly measure it in that way, rather than an estimate from the InBody. So I can't speak to what equation it uses to estimate that. So I have not directly looked at the validity of that device. I don't know if there's papers. I tend to use my own measurement of BMR, but Monica, I don't know if you can speak to that a little bit more.
Yeah, we actually use the Cunningham equation, which directly relates to the lean body mass that is measured. So it's not empirical estimations. So it is very accurate, and that has, been shown. So yeah, just, to address that. Okay, we still have more questions, but let's just do a couple of more if you don't mind, Katie.
Yeah.
What do you think explains the difference of results between DEXA and InBody for appendicular fat-free mass? And I think that's kind of a good follow-up. Could this come from a difference in what DEXA considers as fat-free mass versus InBody?
Yeah, that's a really good question, and I think a lot of it comes down to that quantification of body water, and so it's just a difference in how those devices are measuring or accounting for that fat-free mass or lean body component. And so what the InBody is using is those resistance and reactance, and really influenced by that body water component, whereas DEXA is relying on pixel attenuation or brightness of those pixels. And so what it does is it first quantifies the brightest pixels, which are the bone in that X-ray image, and then it takes the next brightest one, so the more gray pixels, and it quantifies that as lean mass, and then it takes the darkest pixels, which is going to be the fat mass. And something to remember with DEXA is there's actually a lot of prediction involved with those measurements. So you're only getting a 2D image, and we have to extrapolate to a 3D image. So it then takes those pixels and has to plug it into equations and estimate three-dimensionally what's happening with those different components. So there was a lot of estimation happening. And so, yeah, go ahead.
That's important to know. Yeah, that's important to know, definitely. Okay, so one last question here from the audience. How can we get more clinicians to use body composition to assess muscle-related disease risk and adiposity-related disease risks?
Yeah, that's an excellent question, and something we try to drive home in a lot of the research that we do. And that's a tricky question. You know, it's just going to take time. It takes a long time for research to carry over to practice, and also convincing, you know, clinics that they need something like an InBody. And even if they get it, do they understand what the different components are telling them? Because right now, just not trying to bash on physicians, but the focus of their training is medicine. And so body composition's not a major focus of their training. They maybe know its incorporations, but it's not like they have extensive training that they're measuring these components and what they mean and the importance. I think they know the importance. So I think it's just going to take time for it to kind of trickle over. And I think the ones that maybe it's more of a concern for their populations, it gets implemented more. I don't have an easy answer for that translational piece, but I think as a researcher, it's something I see the need for it too. And so I think it's just awareness. And, you know, a lot of our studies, we try to work with physicians. The bariatric study was a good example. We work directly with physicians on that one. So I think just trying to work together, collaborations are good. So.
Thank you so much, Dr. Hirsch, for taking the time to talk to us today again. We're very grateful for you for sharing your work with us. And as you can see here in the slide, if you need to reach out to Dr. Hirsch, please use the email shown in the screen. To all attendees, we hope this was both informative and inspiring, and that you will consider joining us in future webinars. If you need to reach out to us, please contact us at clinical@inbody.com, as shown on the screen. Also, if you want to have a conversation with us about applications, or if you may be interested in sharing your research with us and other researchers through this forum. Also, please contact us if you need a certificate of attendance to apply for CPEU credits or CPE credits if it applies to you. Again, thank you so much, Dr. Hirsch.
Thank you.